Good evening, everyone. It's 6:15, and I'm going to go ahead and get started. My name is Chris Holsinger. I'm one of the head neck surgeons here in the Department of Otolaryngology at Stanford. It's a real pleasure tonight to introduce Dr. Randy Weber, who's going to be giving our first grand rounds of the year on value-based treatment for head and neck cancer. It's about an interesting pilot that Randy and others at MD Anderson are doing with United Healthcare, and there's probably nothing more pressing in this era of healthcare change than this issue of cost and finance and value. And Randy, I think, is going to present a very interesting experience tonight. I want to acknowledge this is a little bit larger turnout than most of our ENT grand rounds, and I want to thank, of course, Rob Jackler and Raj Bahal, who are co-hosting a great visit today with Randy. Thank you very much, and also the Dean, who's quite often part of our grand rounds, but we have a very distinguished group of colleagues outside the department tonight, and I just want to acknowledge a few of them. Please forgive me if I miss some of you. But Doug Blaney, our Cancer Center Coordinator for Quality. I see Ning Tang, who's our Senior Medical Director studying value-based approaches as well. Julie Porter, and several other members of the value team, and Joe Hopkins in the background. So I'm going to be very brief so we can get Dr. Weber up here and to get you all home to your families and evening. But I have to thank Randy so much for all the mentorship over the years, and it was great to spend the day with him here. It was fun to see him interacting with all the Stanford folks. Some of you outside the department might not know that Randy is the current American Board of Otolaryngology President. That's an honor bestowed upon him earlier this summer. It's a really a true feat in his career, and I just wanted to publicly congratulate you and acknowledge this accomplishment. Thank you. So that's pretty good from a good old boy from Chattanooga, Tennessee, where he hails from. He went to Baylor College of Medicine, where he was a resident, and he completed the MD Anderson Fellowship in Head and Neck Surgical Oncology in 1985 and was mentored there by Bob Byers and Helmut Geffert. He was on the faculty at MD Anderson for the next, just doing the quick math here, about the next 8 or 9 years. And then he went to the University of Pennsylvania, where he directed the Division of Head and Neck Surgery, and he was also vice chair with David Kennedy leading that department. In 2003, he became chief and chairman of the Department of Head and Neck Surgery at MD Anderson, where he has remained since. At MD Anderson, he not only plays a prominent role leading as a leading surgical chair, but he also directs the newly founded surgical committee and plays a really important role in the way surgical care is delivered at MD Anderson. And so with that, I'll turn it over to Randy, and really look forward to a great talk tonight. Thanks.
Thanks, Chris. Appreciate it. It's an honor to be here. I'm actually back for a second visit. I was invited by Dr. Jackler a few years ago to be your speaker at graduation. That was a memorable visit. I appreciate Dr. Miner being here, a good friend. He's always been a friend, but now that he's dean, I'm a little nervous to give this talk in front of him. Also, Dr. Jackler, who I've known him for many years, and he should be very proud of the outstanding program he's created here. And we miss Chris. Chris, the energy level in the department's down 25% since Chris left. So I've been talking all day. Can we just cut to the questions maybe, or? No, I'm just kidding. I put this talk together, so I'm darn well going to deliver it. One question for the residents. Do any of you know what this is? Right. I didn't know if they still had these here in Silicon Valley, but we're still using them back where I'm from. But anyway, it's great to be here. Appreciate the opportunity to speak. And I have no disclosures, but I would like to acknowledge really the true leaders of our bundled payment pilot have really been Tom Walters, who's head of our Institute for Cancer Care Excellence. He's worked closely with Michael Porter and Ron Walters, who is very instrumental in working with our managed care payers and really developed this alliance with United Healthcare that allowed us to create the pilot. And then the two program directors are Tracy Spinks and Alexis Guzman. So you've probably seen this. This is referred to as the value proposition in healthcare. Michael Porter is a healthcare economist at Harvard. He's a university chair. He's an amazing speaker. I heard him first speak in 2006 at MD Anderson, and he really just got me intrigued and really fired up about the value of healthcare delivery, how important it is. It's based on quality. And what resonated with me, I think, is one is the huge expenditures for healthcare today, and it's unsustainable. But also the fact that when you think about it, we're all going to be patients someday. So we want the very best care possible at the lowest possible cost, and that's really value. So the definition of value-based care is the best outcome for the lowest cost. And he's an economist, and what he had discussed and written about and taught all of his career was about competition, and he has served as advisors to presidents. But basically it's in the area of healthcare, it's providers and institutions that provide value-based care will have a competitive advantage. So if we can get better outcomes than the institution across the street for the same or lower cost, we have a competitive advantage, and we're going to have a larger market share. At the end of the day, if we all followed that principle, the quality of health care would be improved and the cost of health care would be reduced. So some of the drivers towards value is really the cost of health care is unsustainable. We have to move away from fee-for-service. The more I do, the more I get paid. And we have to drive incentives to control costs by providers, and the way to do that is really that we as providers accept some of the risk, the financial risk for providing care. Medicare is moving towards this. There's alternative payment models that are already underway. 30% of reimbursement is under this new scheme of payment, and it'll increase to 50% by 2018. And we're already in the environment of value-based payment, where you're paid for outcomes and not quantity of care delivered. And by 2018, CMS will be reimbursing based on value in about 90% of claims. So the legacy system of how we delivered care, it was organized around a department, a provider, or a specialty. Measures were process and compliance, submitting charges that were justified. It was really fee-for-service, and it was very fragmented. You might see your head and neck surgeon down the street who would send you across town to the radiation doctor, who would then send you to the medical oncologist. Poor communication among the providers, lack of good communication, and significant delays in establishing treatment. So the value-based system is really advocates organizing care around integrated practice unit and around patient medical conditions. You measure outcomes and costs for every patient. Moving towards an alternative payment scheme where you're paid for episodes of care, and both the payer and the provider assume some of the risk for delivering that care. Expanded geographic reach, so larger successful programs will have a greater reach, attract more patients. That improves efficiency, rapid acquisition of experience. And it's built upon information technology, because you can't do any of these things unless you're able to capture all the data elements needed to report your outcomes, identify problematic areas that increase costs without benefit, and you have data that's actually actionable. So the integrated practice unit is the fundamental organizational basis for all of our treatment centers at MD Anderson. So the treatment modalities are really at the center. So it varies for centers, but it's basically surgery, radiation, medical oncology. that are also supported by diagnostic radiology and pathology. So those are the core. But it really does take a village to care for these patients. So you have our trainees, you have mid-level providers, you have social workers, psychiatrists, addiction specialists. All of us come together in each of these centers in a way where we deliver patient-centered care. So we're all co-located, and there's rapid and efficient communication among the entire team. When you look at the head and neck center, just to drill down on one of these integrated practice units, this is how it's structured. So we refer to this as the cycle of care. So before I ever see a patient, I get some basic information from our intake center or from the provider. So I know the diagnosis, prior treatment, what imaging or other modalities of investigation they've had. So I can pre-order, based on that diagnosis, the appropriate investigational modalities and all the appropriate consults. I can even refer them ahead of time to smoking addiction therapy. And the reason why we do that is that it facilitates input, diagnosis, staging, and our goal is to get the patient to our multidisciplinary conference within 5 business days. From there, they go into treatment. Our goal is to try to get them under treatment within 2 to 3 weeks. The treatment package time is important. We'll talk a little bit more about that. That's an important process metric from the day they start treatment to when they finish. Once they complete treatment, there's a recovery phase. Then they enter surveillance. And at about 2 to 3 years, we actually transition them from our acute care environment to survivorship. Survivorship are for patients who are free of disease, but they still need surveillance. We need to manage their late effects. We also need to monitor them for and decrease the risk of second primary. So we do colon screening, prostate, breast screening. We treat them for smoking relapse, all of those things that are best managed in that surveillance environment. And so we refer to this as the cycle of care, but it's very integrated where all the practitioners work together in a very efficient way. So this is just some data. These are called process metrics. Our average time from when I call and I say I want this patient to see Dr. Holsinger in the Head and Neck Center is on the average of 7 days. It varies between 6 and 8 days. After they are seen in the clinic, we try to make sure that all of their appointments and their evaluations are completed. So the average time to multidisciplinary conference is usually 5 to 7 days. New patient appointment to first treatment is 20 days, and new appointment to final treatment is 63 days, depending upon how they're treated. So let me just show you some data. If you look here at the bottom, surgery and multimodality therapy, we complete that within 100 days. And there's data that shows if you can complete the package time of surgery and radiation for a patient with head and neck cancer within 100 days, they do better than if the treatment's much more protracted. And one of my colleagues, David Rosenthal, did a study. So that's why we use that benchmarking. We're continually measuring this process metric to know how long does it take us to get the patient in, work them up, present them to conference, give them a treatment plan, and complete that treatment. Those are all measures that we try to capture in real time. So to increase value, you need to improve outcomes or you need to decrease costs. And so without data, you won't really be able to determine which way your value equation is going. And so we have made a big effort to try to capture the appropriate data to inform us of where we are in that continuum of value-based care. Every patient has an experience in your center, either in your hospital or in your head or in your disease site center. So about 5 years ago, based on our interest in pursuing value, we developed a program called Enhancing the Patient Experience. And we based it on the IOM 6 aims. We want to make our care safe as possible, timely, get the patient in as quickly as we can, effective, meaning providing evidence-based care, efficient, we don't want to waste time, we want to make sure that they complete their treatment according to established guidelines, equitable so that regardless of whether they're insured or they're indigent, we want to provide equitable care. And it has to be patient-centered. So the patients are part of the treatment decisions and play a major role in how they're cared for. Let me back up one. So at the inception of entering into this pilot of episode-based payments, we needed to look at our resource utilization, because if you don't know your costs, or if you have great variability in care, if you have a lot of disutility of care, the cost of the care you deliver will go up. And in a fixed payment environment, you have to control your costs. And if you don't do that, then you're likely going to lose a significant amount of money in this environment of episode-based payments. So there are several different projects that are ongoing concurrently in our center under that umbrella of enhancing the patient experience. New patient access time. It got as high as 15 business days, so that's 3 weeks. What patient wants to wait 3 weeks to see a doctor when you have a diagnosis of cancer? So we put in the classical process improvement methodology, and we were able to get that down to about 6 to 8 days, which is below the institutional benchmark. Overall patient cycle time, again, we keep a constant eye on that. Are we moving patients through diagnosis, treatment, et cetera? One area that was ripe for intervention was our multidisciplinary follow-up for patients. So we refer to that as continuity of care, and I'll share some more details with you on that. But typically, all of us tend to follow the patients regardless of how they were treated. So surgeons still follow patients who got radiation or chemoradiation, and if they got surgery and radiation, the radiation oncologist would also follow them. But it was disorganized. There were multiple redundant appointments, multiple redundant tests, and so you can imagine you're ordering things and subjecting the patient to things that are costly but don't provide any benefit. So unless we focused on that in a bundled payment environment, it's like throwing money out the window. So we had to look at that and establish a more defined process for follow-up that was less expensive. And the other thing we wanted to look at was surgical outcomes, because surgery is expensive and complications of surgery really drive up your costs significantly. So we wanted to get a handle on those two things as we entered into this bundled payment scheme. So I'm going to talk first about the continuity of care. We wanted to standardize follow-up for patients treated for non-surgically for oropharynx, larynx, nasopharynx, and hypopharynx cancer, reduce redundant diagnostic studies and laboratory tests. We wanted to increase efficiency, so by putting this in place, we could actually decrease the volume of our clinics, decrease wait time, increase patient satisfaction, and by decompressing our clinics, we could actually see more new patients because we weren't seeing so many follow-ups. So I'm going to give you some baseline data. We implemented this in 2009. We started with 245 non-surgical patients, and our key outcome measures were the number of appointments and the number of scans that were ordered and the time between appointments. So in the old days, they might see me for their tonsil cancer follow-up. A week later, they might see radiation. A week later, they might see medical oncology. You can imagine from the patient's perspective, 3 appointments, 3 weeks, waiting in the waiting room, and we're all doing the same thing. And there were multiple tests that were ordered that were redundant. So that was really the focus of what we were trying to do. So what we found in our baseline data is that 43% of the appointments were within 3 months. And if a patient's NED and they're not having a problem, there's no reason they need to be seen more than once in 3 months. And even 11% of them were getting multiple scans within 3 months without a proper indication. So this is what our interventions were. We wanted to identify the critical timing for follow-up and treatment decision making. We defined the minimum testing needed in that follow-up pathway. We standardized orders, and we standardized in rotation which physicians would see the patient at the next visit. And we made it equal responsibility. Even though I didn't treat the patient with radiation, they came to see me first. I'm their primary cancer physician, and therefore I'm going to continue to see them. We had to train the staff in how to do this. And we informed the patient. We actually gave the patient a passport that said, this is your 3-month follow-up, this is who you're going to see, and these are the tests that you're going to have. So they were informed. And so if a patient saw he had a redundant CT scan, they brought it to our attention and we canceled the second scan. So you got to engage the patient in this as well. This is just what it looks like. We don't have to go into detail. It's a leapfrog. The interval of follow-up and imaging increases as the patient gets further out from treatment, but we all bought into this and we all agreed to do it. I'll never forget, it was 2 or 3 patients in a row. They had been treated for oropharynx cancer and they were in my clinic. And I said, well, when are you seeing radiation again? And they said, well, we don't need to go back. They said they could be followed up in the surgery clinic. That's when the light bulb went off in my head that, hey, this is shared responsibility. We're all going to see the patients. So if you look here, this was the old days. You can see this patient, and this is pretty outrageous. They had a CT scan ordered, and then within a week or 2 later, without reason, they had a PET scan ordered. So that's just a huge waste of resources. And then in our new, once we implemented COC, this is a typical follow-up for a patient. They see the provider and they get a CT scan, period. May need some lab, but generally it's just the minimum number of tests that we've all agreed to place that patient on pathway. We're still not perfect. We have about 70% of our patients on pathway, but it's increasing. We look at it every month. And when we see providers that aren't following the rules, then we do some personal persuasion to get them back on board. Sometimes more than personal persuasion. But so I'll just give you a snapshot. This data is going to be presented this winter at the multidisciplinary head and neck meeting. But Dr. Beadle provided this for me. This is just a snapshot of our patients. So there were 131 just oropharynx patients treated over the year interval. We have aggregate data from the end of radiation up to 2 years follow-up. And this included all clinic visits. So the mean number of visits was just a little under 8, the range being 3 to 19. The median was 8. And ideally, if they were strictly on the pathway, they should be seen 8 to 10 times over a 2-year interval. So pretty good. I mean, we're demonstrating that we're adhering to our process. And then this is just data on diagnostic studies. We don't order routinely PET scans. Our principal modality for follow-up is a CT. And you can see that the mean number of scans was about 6.3 over a 2-year interval. Ideally, it should be between 7 and 8. One of the benefits of this study that we'll learn later is how often do patients need to be imaged. We're going to have very good data since we're imaging patients routinely on how beneficial it is and how cost effective. And so that's a separate study we'll do. It may be if your first post-treatment scan is negative for oropharynx, HPV cancer, you don't need another one until you develop a symptom. So that's something that we're going to learn from this over time. I'm going to move on to the surgeon side of this because the surgeons can have a very big impact on the cost of care. Some of you may have seen this data before. I presented it elsewhere. But basically, we took all of our surgical cases and we divided them into high and low acuity. The high acuity cases were patients who had major resections and reconstruction. The low acuity cases were the bread and butter head and neck, laryngoscopy, glossectomy and neck dissection, parotidectomy, neck dissection alone. Procedures that we would consider low acuity, 1 day in the hospital, maybe 2 at most. So we wanted to provide for each surgeon their own respective data, but it had to be risk adjusted because I see different patients than Chris Holsinger would see. And we knew as we built this database and we had more and more patients in it, it would sort of diminish the impact of heterogeneity that's going to be there among all of our practices. But that we didn't want to stop there. We didn't want to just give you a snapshot of your performance. We wanted to give you your performance where you were in relation to your peers and then remeasure it at a later date to see if it had an impact. So these are our outcome measures. These are standard sort of surgical outcomes. How long is the patient in the hospital? For a low acuity procedure, did they receive more than 1 unit of blood? If they had any of these occurrences, this is a negative outcome. If they returned to the OR, if they had a surgical infection, if they were readmitted, or if they, obviously if they died, that's a negative outcome. For the high acuity cases, the only difference was longer length of stay. So any patient that stayed more than 11 days on average was considered a negative outcome, or if they had more than 2 units of blood. But you also have to risk adjust for comorbid conditions, because we know if you have significant comorbidity, you're more likely to have a longer hospital stay, more likely to have a complication. And also it's important if a patient has comorbidity that you manage it prospectively. Get them to the medical clinic, make sure their blood pressure is optimized. The other things that you can do to intervene, smoking cessation as quickly as possible prior to surgery. So, and then we looked at the individual surgeon. So this is for low acuity cases. Does anyone want to know where Dr. Holsinger was? He was in the mix here. Well, he was not Jay, so I can tell you that. Jay was a surgeon that had higher than average negative outcomes. And so, I actually had to have a conversation with this surgeon. He saw where he was in relation to his other faculty members, and he was an outlier. And that also was true for the high acuity cases. So the factors that affect outcome, a negative outcome, is the surgeon, the comorbid conditions of the patient, and the acuity of the procedure. So again, this is pretty clear data that this surgeon was having worse outcomes. Now, granted, he took care of patients that were sicker, but so did Surgeon D, but Surgeon D had much fewer negative occurrences. So we gave everyone their first data set, and then we remeasured it with a second cohort of patients. And we used that to see if it would make an impact. And so actually we looked at it in 2 ways. We looked at the departmental data for both low and high acuity cases. We rolled it all up. And so what we found was a significant reduction in length of stay for high acuity cases and a significant reduction in length of stay for low acuity cases. But we also saw something that we weren't happy with, and that was an increase in blood usage for both low and high acuity patients. And that's the subject of another performance improvement project that we have underway. We did reduce our return to the OR somewhat. It would approach significance in the high acuity cases. It was not significant in the low acuity cases. Our 30-day readmission for the high acuity cases was cut in half. And if you look overall in aggregate, there were fewer negative occurrences in the second cohort than the first cohort. So we think that providing this feedback data is important. Perhaps a surgeon handles the preoperative issues better, or they spend longer drying up the wound so that they don't get a hematoma. The cause and effect is a little difficult to postulate because there could be confounders, but at any rate, the end result is what we wanted, better outcomes. And better outcomes are less expensive. So if you just look at this in aggregate, you can see that for the most part, most surgeons improve their outcomes between the 2 intervals that we measured. Some went up a little bit, but to a great degree, we all began to cluster here in the middle. Chris, I forgot where you were, but you're in here somewhere. Okay. He didn't get a call to my office to, can we discuss your outcomes? I remember that. So we've talked about the outcomes. Now we have to talk a little bit about costs. So going back to Porter and Teesberg, they described 3 tiers of outcome, tier 1, 2, and 3. So tier 1 for a cancer patient, number 1 is survival. They all want to live. Tier 2 is time to recovery. When can they go back to work? Can they swallow without a feeding tube? Can they breathe and talk without a trach? And then sustainability of recovery over time. Are they back to their activities of daily living? Do they get second primaries? Do they have complications of treatment? They describe these as the 3 tiers. And we'll come back to that when we talk about the bundled payments, because we have to look at outcomes as we treat patients within the bundle. So tier 1 is survival, and I will admit we don't have great data at my institution. I can't go to my computer and pull up the last 3 years of oral cavity cancers and have it spit out overall survival, disease-free survival, disease-specific survival. So we have to use our registry data. And this is from our tumor registry. So what you can see from this is that decade over decade, our outcomes, our survival for oropharynx cancer have improved. It's improved a great deal over the last decade from 2000 compared to 1990. Does anyone know the reason for that? Correct. Look, the otologist got the answer. That's amazing. But that's true. It's gone up significantly because of HPV is associated with better survival. But we can go a little further. We can compare our survival data to SEER data. So this is SEER 9, and this is SEER 17, and this is our aggregate data for survival for oropharynx cancer. So we can benchmark our outcomes at least to the SEER data, and I know that there's some issues with that. But these are the sort of tier 1 reports that we can provide on our outcomes. You have to know your costs. You would never want to enter into a episode-based payment plan without knowing your costs. Tom Feely spent a lot of time with David Kaplan and Michael Porter in Boston learning the time-driven activity-based costing. We use that to try to really drill down on every aspect of that patient's care and what does it cost. If you know that, then you're much more comfortable as you consider negotiating on a bundled payment. So you have to map the process. First you select the condition. What we did was we selected head and neck cancer care. We had to define the blueprint, what's the process of all the things that happen to them, and you have to map out each step from the very first day they walk in the institution to their last treatment for follow-up. You have to obtain time estimates for each of those steps. You have to cost out each activity, the supplies, the space, the personnel, the scopes. You have to depreciate those things that are depreciable. And you multiply the resource capacity, cost rate, and the resource process time to compute the total cost. I'm not an expert in this. It's very complicated and arcane, and it's got formulas in it that you can't believe. But at any rate, it is a way of using cost methodology to determine how much it costs you to care for a patient. It is a manual process. When we did this, what we did was map out all of the process in our clinic, including the inpatient stay and the operative care or radiation or chemo the patient received, and it required us as clinicians to sit down with the finance people and the TDABC experts to develop this complex map and cost out every aspect of their care. This is just what the map looks like. Here's the patient coming in the front door. You have fellows, residents, faculty, nurses, social workers, scopes, blood tests. All of that gets mapped out in this process based on a particular disease. So Dr. Feely and the rest of us working together, we took almost 2,500 cases. They're analytic, meaning they've never been treated before, and we looked at the costs of care, including physician services and indirect costs, and what we found was that 90% of the cost of care occurs in their first year, and that there are outliers and they're significant, and it was really patients who had a complication of care. So this just shows it looking at the cost of care pre-treatment. The middle bars are treatment, and the last bars on the far right there are the follow-up. And we broke it down into larynx, oral cavity, and oropharynx. A couple of interesting things is stage didn't really affect costs that much, nor did site. But what we did learn is there's only about 10 to 12% of the cost is in the diagnostic phase, and 70 to 75% of the costs are in the treatment phase, and then the follow-up while you're trying to recover from treatment. Maybe patients have continued dysphagia, you're putting a peg in them, or some patients obviously recur. So about 25% of the costs are at that after treatment is completed. And so this just maps out the costs according to stage. It just depicts it in a different way. But one of the things that we were really interested in were these outliers. Some of these patients, their total charges were over $500,000. One was even $1 million. And what we found was that these were patients that had significant complications of care, whether it was a complication of surgery or radiation or chemoradiation. So the episode-based payment or bundled payment is a single prospective and comprehensive payment that's made for all services during a predefined episode of care, regardless of the actual services utilized by the patient. And as I said at the beginning, it transfers some of the risk from the payer to the provider. So as it is in fee-for-service, you do an intervention, you submit the bill, you get a negotiated fee for the bill that you just submitted. Under the bundled payment, you get a lump sum, you provide the care, and hopefully you're able to make a margin or a profit from that bundled payment that you received. So some of the benefits, it's greater flexibility to deliver care. One of the major things that it does for us, which improves physician satisfaction, is I don't have to call and ask the psychiatrist on the phone, can I get a CT scan for a new patient that's in my clinic? So it really does away with this peer-to-peer and this pre-certification, because you've been paid for it. If you need the test, you can order the test. It does incentivize more standardized care. It incentivizes less variation. Remember, we all need to make a margin on the care we deliver, because if there's no margin, there's no mission. That $2 billion hospital that you're building, that's built from operational sources or income. It's built from philanthropy, and it's built on debt. So you have to make a profit margin on the care that you deliver. So you got to manage the risk so that you can make a margin. So this is how we developed the bundles. We established a roadmap. So what diseases would we cover? We would identify clinical partners that come together to care for that patient. We would determine the length and the cost of the bundle through economic modeling. We would organize it around evidence-based care. So we use guidelines. And so we knew what interventions were typical for certain diseases, site and stage. We had to identify a partner that was willing to do it, which ultimately was United Healthcare. And we had to negotiate with one another in a way that was open and honest. What was the rationale for starting with head and neck? We've had a multidisciplinary team for 35 years at our institution. We work well together. We do guideline-based therapy. We jointly collaborate on protocols. We're all paid a salary, so it's not fee-for-service. It doesn't matter to me if a patient gets radiation. I'm fine with that. I get credit for having brought the patient into the institution. So it's more manageable because it's a lower volume, and we had this already established integrated patient care unit. We had well-defined treatment endpoints and a pretty standardized way of delivering care. We wanted to streamline it. We didn't want to make this a burden for the surgeon, for the physicians, or the patients. We wanted to make sure that we were blinded. You know, there could be incentive for withholding care in a bundled payment, because the more care you deliver, the more you pay for out of your bundle. So we as physicians were blinded as to whether or not the patient was on the bundle. We wanted to decrease the paperwork, so we had a fair amount of institutional support on the administrative side. And the goal of this is to make it scalable. So if it works in head and neck, can we broaden it out to thoracic, to GI, to breast, and other disease sites? And there's a lot that we would learn from engaging in this pilot. So there were 6 primary teams with a team lead for each team. It included finance, claims, contracts, the clinical care, which I was most involved in, customer service. Again, we didn't want to burden the patients with this. And then we had to measure outcomes as part of the bundle, both for our information, but also the payer had some specific requests for outcome data. We also brought in all the related services as part of the patient care pathway. We did bring in an outside consultant to make sure we weren't making some crazy assumptions with this, and they thought that our assumptions were reasonable, and they were helpful in one way. They provided us some good negotiation strategies to take to the payer, which was UHC. I'm not going to go over these in detail except to show you that these teams are important. You have to have people that are very knowledgeable, so our CFO was on one of the teams. Jim Incalcaterra was an expert at financial modeling, so he could look at different permutations of treatment, disease site and stage, and model that to determine the cost based on TDABC, how much more it would cost if a patient got a pneumonia and went to the ICU for a week. So the modeling was very important. I think they ran models, almost 100,000 different permutations to really try to figure out our costs. So we also had to put the financial infrastructure in place to monitor the cost of care and to compare that to fee-for-service. So we were doing concurrent assessment of what we were spending within the bundle and what we would have spent or what we would have received in a fee-for-service environment. And then clinical care was the group that I led. Had a lot of meetings with our multidisciplinary team to make sure that everyone was aware of the pilot, that they were blinded, but think about the care you're delivering. Do you need that scan? Is it important for the patient's well-being and for treating their disease? Again, then the outcomes was led by Ehab Hanna. We wanted to identify both outcome and quality measures, including benchmarks, implement data collection methodologies, analysis and reporting, and develop a system to track the patient's outcomes and costs in real time. The disease sites that we decided to include were oral cavity, larynx, oropharynx, salivary gland. These were newly diagnosed patients, untreated, but all curable, stage 1 to 4. And again, we worked with UHC. So one thing that we did differently, we excluded the diagnostic studies from the bundle. This remained fee-for-service. The reason we did that is a lot of patients come in with studies, or they may want to get a scan closer to home. So we wanted to keep that fee-for-service. But the bundle triggers as soon as the treatment starts, except for radiation oncology. Within the bundle was all the pre-treatment setup. So that was included. But every aspect of treatment, if they got a pneumonia, if they went back to the OR for a hematoma, every aspect of care for that 1 year was included in the bundle. After 1 year, it reverted back to fee-for-service in the follow-up phase. So the bundle really covered 1 year. We divided first into 4 bundles, and then I showed them the data from the comorbidity, how much that can impact a negative outcome. So they redid all the modeling looking at patients with less than 2 comorbid conditions or 2 or more. So bundle A is surgery alone, and then let me see, I got to go back one. So we initially had 4 bundles, but then when we put the comorbid conditions into it, we actually had to subdivide each treatment modality into 2. So blue A is surgery alone, less than 2 more comorbid conditions, and blue B was 2 or greater comorbid conditions, surgery alone. The others were surgery, chemotherapy and radiation, surgery and radiation, surgery, radiation, chemotherapy, and then the most expensive bundle or most complicated one was surgery with reconstruction, with radiation, with or without chemotherapy. And this is how the bundles stratified out. You can see the standard deviations here, and these dots are the outliers. These were the ones that had complications that increase the cost of care. You can see not only does comorbidity increase the cost of care, but also complications, significantly so. So how do we manage the risk under the bundle? One was putting in the comorbid conditions. We also had to include a stop loss because one outlier, if their cost of care was $500 or $1 million, could really wipe out all of your margins. So there's a stop loss where when the cost exceeds a certain amount, you revert back to fee-for-service. And we have real-time dashboards for all of the data in aggregate, but also for individual patients. So this is going to be hard to see, but this first is really the number of patients in each bundle. So the majority of patients are getting radiation or radiation and chemotherapy. This is the income received for each bundle. This is some of the other data related to care, such as inpatient length of stay. You can see it's greater for comorbid conditions as opposed to fewer comorbid conditions. Emergency center visits can also increase with comorbid conditions. And then we looked at the total cost of care and the reimbursement to look at that delta between where the stop loss was and the maximum payment that we received. To date, we haven't had any that have triggered the stop loss. I'm sure that's not lost on the payer. That means that we calculated our bundles correctly. So we have had patients that have reached almost the trigger point but have not exceeded it yet. I can't give you the actual data because it's proprietary, but I can say that from a financial perspective, we're performing as good or better than fee-for-service under this bundled payments system. Outcome measures, we developed those in a joint collaboration, so these are tied to the 3 tiers of outcome: survival, return to daily activities, ER visits, readmissions. Those are disutility of care, so we tracked all of those things. How expensive is the care that we deliver versus the national average? The payer is especially interested in that. How long does it take a patient to get into our system and get through their treatment? Those are the types of metrics that we were capturing, and we have all of that captured in real time. For outcome measures as far as function and quality of life, we use validated instruments. For this study, we chose to use the symptom inventory called the MDACC head and neck. And this is just the timeline for first enrollment through treatment, the outcome measures, mortality, morbidity, disutility of care, and then patient-reported outcomes. So I don't know if you're familiar with the MDACC, but it's a validated symptom inventory that we developed. And if a patient rates any category, any domain 7 or higher, that means extreme distress or a situation that requires intervention. I'm not going to go through all these in detail, but there's some critical things like pain, fatigue, nausea, loss of memory. We capture this on every patient at every visit. And when they are at 7 or higher, it triggers an intervention. And we can use that data to monitor their recovery. So as you capture this data longitudinally, these patient-reported outcomes, in addition to their disease status, you can measure the time to recovery in that second tier that we talked about. We also track G-tubes when they're put in, when they're taken out, and tracheostomy tubes.